So today I'll be discussing on acute complications of hemodialysis. So the target audience it is primarily for the dialysis technicians and the nurses. So I'll be dealing only with the basic concepts and the basic management of the acute complications that you encounter during hemodialysis. I won't be going into much theoretical aspects of all the complications because it is for a different audience. So basically, it is only for the dialysis technicians and nurses. So I have modified my talk. So we'll be discussing the commonly encountered complications which happen in a hemodialysis unit. How do you manage these complications and how do you recognize these complications? And it will be purely a case-based discussion. So what happens when a patient develops a particular complication? So keep in mind about all the presentations that I put forward as cases and draw your own conclusions before I reveal the answers. So this is the first scenario. So this first scenario is a patient with a hypotension. So we have a patient who is on dialysis, that is Mr. X. He is a 64-year-old male who is on a twice weekly maintenance hemodialysis. Basic problem is a diabetic kidney disease, which led to chronic kidney disease. So there's a background history of diabetes, hypertension, coronary artery disease, and peripheral neuropathy. And with a dry weight, which was last assessed about 4 weeks back, which was reported as 72 kilos and was started on hemodialysis. The axis being a right radiocephalic arteriovenous fistula. So he came to the dialysis unit with a weight of 77 kilos. And the hemodialysis prescription was as follows, which was started by the dialysis technician. It was the 4 hours dialysis. The weight loss was put at 5 kilos. And he was on systemic heparin. And the blood flow was around 300 ml per minute. And 2 hours into dialysis, the patient suddenly developed hypotension with a systolic blood pressure of 90 millimeters of mercury. And he denies any other cardiac symptoms like chest pain. So what is the question with regards to this case is what is the cause of hypertension? How do you treat this? And how do you prevent this happening on the next session of dialysis? So this is a common problem that we encounter during dialysis. So hypertension, if you look at the causes of the complications of dialysis, the most common complication of hypertension is the most common complication of hemodialysis is hypertension. And we'll go into what happens, what is the reason for hypertension. So this is a depiction of the dialysis filter. So the blood comes in from the patient. It goes out of the blood end of the filter, and you have the dialysis fluid coming in, and the ultrafiltrate goes out as a spent dialysate. And because of the ultrafiltration, only the water moves from the blood compartment into the dialysate compartment. So this movement of the water under the influence of a transmembrane pressure is known as ultrafiltration. So this is a reason why water moves from the blood compartment into the dialysate compartment, because there is a pressure gradient across the dialysate membrane. So when the water moves, so this is a plasma, and this is a compartment that is represented within the hemodialysis filter. So just imagine this as a hemodialysis filter, and we are removing the water from the hemodialysis, from the plasma component of the blood. So the movement of the water is actually 60% of the water is in the intracellular space. And from the intracellular space, when you are drawing out water from the blood compartment, the water should move from the intracellular compartment into the interstitial compartment. And from the interstitial compartment, it should move into the plasma compartment. And this movement of the plasma, water across all the compartments, that is from the intracellular compartment, from the interstitial compartment into the blood, is known as a refilling rate. So this is known as a plasma refilling rate. So when you are taking out more fluid faster than the plasma refilling rate, what will happen is that the patient will develop hypertension. So you are removing water at, say, for example, you are removing water at a rate of around 500 ml per hour. But the ultrafiltration, that the plasma refilling rate is only 400. So you are running a deficit of about 100 ml per hour. So that it lead to a decrease in the water content of the plasma, and the patient will develop hypertension. So this is the most common cause of hypertension. So whatever it is, the most common cause of hypertension is excessive fluid removal. So just concentrate on the circles which I have drawn. So the most common cause of hypertension is excess fluid removal. There are certain other causes like patient-related causes, which you have to most important things that you remember as one is the patient is on antihypertensive medication. Suppose a patient has taken the full course of antihypertensive medication prior to dialysis, then that patient is more likely to develop hypertension. Then if you take a lot of food during dialysis, whenever you take more food during dialysis, what will happen is that all the blood will be diverted into the gastrointestinal tract to aid the digestion and as well as absorption. So there will be a peripheral lack of blood, and that will lead to hypertension. Then never forget anemia. Anemia is also one of the most important causes of why the patient develops hypertension. Then there are certain dialysis related factors. Dialysis related factors again, like a low dialysate sodium, then other causes are there. And especially if you use acetate dialysis, that can lead to hypertension. And another cause is the cardiac factors, like the patient can have an arrhythmia, like an atrial fibrillation, then myocardial infarction, all these things. So these are in general, the causes of intradialytic hypertension. Uh, Apart from these, there are other causes which we'll discuss in the case scenarios later. One is a dialysis reaction, other is air embolism, other is hemolysis. All these things again can lead to intradialytic hypertension. But whatever be it, remember that the most important cause is excess fluid removal. So what will you do when the patient develops hypertension? So this is how you treat the hypertension. So first, decrease or stop the ultrafiltration rate. You put the patient on a Trendelenburg position. Trendelenburg position is nothing but the patient lies supine and the foot end of the patient is elevated. Then you start the patient on oxygen therapy. And if all the measures fail, then you have to give saline bolus, or you have to restore the fluid volume of the patient by giving a saline bolus. Every unit will have its own policy as well as treatment protocols with regards to hypertension. Then how do you prevent this problem happening? So you have to reassess the dry weight quite frequently. So as you recall, the patient in which I have presented as a case scenario, the dry weight was assessed about 4 weeks back, about 1 month when before the patient had an assessment of the dry weight. So you should assess the dry weight either by clinical examination, or if you are working in a very sophisticated center, you can have other methods to assess the dry weight. But often it is a trial and error method. You assess the dry weight by clinical examination. Avoid eating food during the dialysis. No hypertensive treatment should be given before dialysis, and you should reassess the dialysate composition. Then, if the patient has got repeated intradialytic hypertension, you have to assess the cardiac function. You have to treat anemia. Then you can use certain drugs like midodrine. This drug is especially used in patients with liver disease who have a problem in maintaining the blood pressure during dialysis. Then, of course, you can change the modality of dialysis to peritoneal dialysis or other modalities of treatment. So this is in general how you prevent the hypertension happening in subsequent dialysis. So this is the first problem, and this is the most common problem that is seen during dialysis. That is intradialytic hypertension. So just concentrate on the highlighted areas only. So this is intradialytic hypertension. The most common cause, the causes are listed here. The most common cause is excessive ultrafiltration, which exceeds the plasma refilling rate. So one of the most possible reason is the incorrect assessment of the dry weight, and the clinical symptom is low blood pressure, and it can lead to wide variety of symptoms. How do you manage is the patient should be in supine position, minimum ultrafiltration or stop the ultrafiltration, administer oxygen and administer fluid bolus as per the hospital protocol. And prevention is by repeated assessment of the dry weight so as to make it very accurate. And if the patient undergoes repeated intradialytic hypertension, then you can assess by dialysate sodium modeling or profiling of sodium. Then the second scenario. So the scenario 2 is a dialysis patient with seizures. So Miss Y, a 20-year-old female recently diagnosed with a chronic kidney disease stage 5, was commenced on dialysis via right internal jugular vein catheter. And this was her first dialysis, and her blood urea was 340 milligram per deciliter. So And the dialysis prescription was, which was given by the treating doctor, was as follows. So the dialysis prescription was for 1 hour. Weight loss was 1 kg. She was on a rigid heparin. No mention of blood flow or dialysate flow on the charts. So at the end of the dialysis, she threw a generalized tonic-clonic seizure. So this is one complication that can happen in the dialysis unit. So what will you do? The question with regards to the second case scenario is, what will you do? What are the causes of seizures in the dialysis unit? So the seizure has got two phases. One is a tonic phase, the other is a clonic phase. In the tonic phase, the muscles go into repeated episodes of contraction, and the body often assumes an extensor posture with the limbs, the upper limb as well as the lower limb extended and with the head extended. And this is followed by that clonic phase where the patient relaxes and the muscles go into the flex posture. So this is what happens during a seizure. So the first thing that you have to do is first aid for seizure. So you time the seizure, make sure that the surrounding is safe, lay the person on the ground, and you have to loosen any tight clothing and remove any objects that may obstruct the airway. So first and foremost, look at the airway and clear the airway. Especially this is important in elderly patients where they have dentures. So the dentures have to be removed because they can obstruct the airway. And protect the head by placing something soft underneath it. And do not insert any object into the mouth because this can obstruct the airway. So don't put any spoon or any kitchen utensil into the mouth, and always get the help of a trained medical personnel. And whenever possible, gently roll the patient to the left side into a recovery position. This position is known as a recovery position, and this will further protect the airway. And stay with the person until the seizure ends naturally and the person is fully awake. So you have to give the first aid for seizure. And other thing that you have to do is you have to stop the dialysis. Returning of the blood is discretional because it depends upon a lot of other factors as well. So the first thing that you have to do is feel for the pulse and look for any cardiac activity. So it might be a cardiac arrest with a hypoxic encephalopathy. So always rule out a cardiac arrest first. Check the blood sugar and call the doctor as soon as possible. So these are the things that you should do as a dialysis technician. So feel for the pulse, protect the airway, put the patient in a recovery position, terminate the dialysis, check the blood sugars, and call the doctor uh, ASAP. So we'll come to the causes of seizures. So the causes of seizures are again multifactorial. So among these, I'll just highlight on a few things. One is a uremic encephalopathy. Other one is a dialysis disequilibrium syndrome. Another cause can be as hypertensive encephalopathy. As I already told, you have to rule out a cardiac arrest. So feel for the pulse and look for the rhythm on the ECG monitor. Then you have to rule out a focal neurological disease, like the patient can have an intracranial hemorrhage. So that has to be ruled out. Then all the metabolic causes have to be ruled out, like hypocalcemia, hypomagnesemia, and hypoglycemia. Of these, the most important one is hypoglycemia. So check a blood sugar as early as possible. Now we'll come to a bit about the dialysis disequilibrium syndrome. So as I mentioned in the case, this particular lady's blood urea level was 340. So this is a urea particles, this is the blood, this is a brain cell. So you are representing the brain cell here. This is a membrane barrier known as a blood-brain barrier. So the initial urea level was 340. So 340 milligrams of urea is found in the blood here. Same amount of urea will be found in the brain cell also. Now, urea is a very osmotically active agent. So when you dialyze a patient, what will happen? I said, so in this patient, the patient had a 1 hour of dialysis. Probably the blood flow was kept very high. There was no co-current flow. So all the blood urea was removed from the patient's body. So the blood vessel, inside the blood vessel, the urea went down rapidly. And but because of this blood-brain barrier, the urea didn't diffuse from the brain cell into the bloodstream. So the urea level in the brain was very high at the end of dialysis. Now, urea diffuses very slowly from the brain cell into the blood because of this particular blood-brain barrier. Now, because of this urea being an osmotically active substance, it will draw water from the blood into the brain cell. So the brain cell, which is about this volume at the nearing at the end of the dialysis, because of the action of the urea, the water got into the brain cell. The brain cell just got swollen up, and this causes what is a condition known as cerebral edema. So because of the cerebral edema, the patient developed a seizure. So this is a mechanism of dialysis disequilibrium syndrome. So this condition, what the patient had was a dialysis disequilibrium syndrome. So there are certain risk factors like the initial dialysis. All these things are predisposing to dialysis disequilibrium syndrome. In particular, very high urea level, pre-existing neurological conditions, advanced stage, and the highest risk is in the first three dialysis runs. But it can happen in any dialysis, but the highest risk is in the first three dialysis hours. And it happens with the high blood flow rate, longer dialysis duration, and the high dialysate flow. These are the reasons why we keep the initial dialysis in such patients to limit it to 1 hour. You use co-current flow, and you try to remove the urea as slowly as possible. Now, coming to the symptoms and signs, the patient can have headache, restlessness, seizures, nausea, and vomiting. So how do you manage, reduce the pump speed or discontinue treatment? And you have to closely monitor. And you will have to get the help of the medical personnel, as well as most often requires close monitoring of neurological signs. So this is in general about the dialysis disequilibrium. Then all the causes of seizures might not be dialysis disequilibrium. There are other causes as well, like dialysis related causes like dialysis disequilibrium. Intracranial hemorrhage is one thing that you have to be careful. Again, you have to get the help of the treating doctor. Hypoglycemia is one. Severe hypotension and air embolism is another condition. So, all these causes, what you'll always have to get help from your trained medical personnel. Discontinue the dialysis, maintain airway, protect the patient from injury, turn patient to side to prevent aspiration, and the patient protect the patient's access site from separation or dislodgement, and obtains blood samples as requested by the treating doctor. So this is in general how you manage a seizure happening during hemodialysis. Now coming to scenario 3. So there is a patient who is undergoing dialysis. So this is a Mr. A 60-year-old male patient, chronic kidney disease on maintenance dialysis. 3 hours into this dialysis, the dialysis nurse noticed a change in color of the blood in the blood lines. So the blood lines were no longer exhibiting the normal color of the blood. It was just turning pink. And the patient complained of some uneasiness of the chest, and a bedside ECG monitor showed tall T waves on the monitor. So this is a very peculiar situation. So this is the color of the blood running into the dialysis lines. So this is not the normal color of the blood, and this is something like a pink blood running on the blood lines of the dialysis lines. So what is your diagnosis and how do you treat this condition? So this is a problem known as hemolysis. So the hemolysis, so this is a blood cell which is circulating in the blood. This is a plasma. So the hemolysis means rupture of the blood cell, and it will release a content like a hemoglobin into the bloodstream. So it will cause what is known as a hemoglobinemia. So this presence of the hemoglobin in the blood, which gives rise to the particular color of the blood, that color of the blood being turning pink. So the causes can be multifactorial. So the hemolysis by definition means rupture of the erythrocytes with release of hemoglobin, and along with the hemoglobin there will be potassium release into the plasma. Now this potassium which gives rise to all the trouble. So the potassium, when it is released into massive amounts into the blood, and this blood is taken back into the patient's body, can affect the heart, and it can cause cardiac arrest. Now there are certain causes like when you are using a very high blood flow rate with a very small needle gauge or very high access pressure, this can cause hemolysis. Or if there is a problem with the blood pump, so the blood pump keeps on malflowing, this can cause hemolysis. Then there are certain other causes like dialysate related causes. When there is a problem with the temperature sensitivity of the dialysate, leading to a very high dialysate temperature, or when there is a problem with the conductance monitor leading to a altered conductivity, it can lead to lysis of the RBC. So the signs and symptoms are the blood leak alarms or the pink discoloration of the dialysate, and the blood in the dialysate will appear really pink in color. And because of this hyperkalemia, there can be dysarrhythmia, tachycardia, and chest pain. So how do you treat? So this is a condition which requires your immediate action. So stop dialysis, clamp the venous lines, do not return the hemolyzed blood, monitor vital signs, notify the doctor, and you have to collect the patient to an ECG monitor, watch for dysarrhythmia, take the blood of the patient to look for potassium and administer oxygen, and call the doctor as soon as possible. So stop dialysis, clamp the venous lines, don't return the blood, monitor vital signs, and call the doctor. This is what you have to do in a hemolysis. There's a hemolysis. And once the problem has been sorted out, then only after the doctor's advice, you then commence on the patient on dialysis. Now coming to scenario 4. This a Mrs. K, a 78-year-old lady. She started to develop wheezing, abdominal cramps, generalized pruritus, and hypertension about 8 minutes into her dialysis. So, and her vitals were normal pre-dialysis. So she came in with the normal vital signs. She was apparently normal. There was nothing wrong with her when she came to the dialysis. And 8 minutes into her dialysis, she started developing problems. And the technician noticed that this is the first use of a new dialyzer. So what is your diagnosis and what will you do? So this is another common problem that can be encountered in a dialysis unit. So this classically fits into what is known as a type A dialyzer reaction. So dialyzer reaction is a problem with the which is it can be an anaphylaxis type of reaction or an anaphylactoid type of reaction, which can develop due to the dialyzer membrane, and it happens in two different forms. One is type A and the other is type B. And type A is immediate. So this happens within 10 minutes. And the onset is something like an anaphylaxis. Anaphylaxis, as you know, is a problem. It is due to hypersensitivity, and it is a immunoglobulin mediated problem. And a typical classical example is a patient who develops an anaphylactic reaction to penicillin. So it can affect the skin, it can affect the respiratory tract, it can affect the gastrointestinal tract and the hemodynamics. So the patient can have intense pruritus, the patient can have cough, sneezing, wheezing, laryngeal edema, abdominal cramps, feeling of a sense of doom, and the patient can suddenly develop hypertension, rash, and cardiac arrest. So this has to be recognized immediately. So you require, this is why monitoring of the patients is very important during dialysis. You have to be constantly with your patient and monitor all the vitals and pay attention to whatever symptoms that the patient says. So the immediate treatment, so if it is a type A reaction, stop the treatment and do not return blood. Keep access open and consider calling code blue. If you have a code blue team in your hospital, call them, because this can be an anaphylactic reaction and the patient can suddenly develop cardiac arrest. So you should get all the crash cart ready. You have to have the defibrillator, crash cart, everything ready by your side. Call the code blue team or call the duty doctor and be at the side of the patient and stop dialysis and do not return anything. So keep these syringes ready, like epinephrine, steroids, bronchodilators, all these things, and oxygen should be started. And there is another reaction known as a type B reaction. So type B reaction in general happens after the first 10 minutes, usually around 30 minutes later. And the patient will complain of vague symptoms like chest pain, back pain, hypertension, nausea, vomiting. But these symptoms in general improve with the continuation of the dialysis. So this is a type B reaction. So it is it is of importance that you recognize this type A reaction immediately and take necessary action. So this is importance of monitoring the vital signs and accurately diagnosing a type A reaction. So coming to scenario 5. So this is a patient who had a blood in the dialysis circuit. So this patient is a Mr. B, a 70-year-old male who was started on his routine hemodialysis schedule. And 2 hours into the dialysis, a nurse noticed an excess amount of air in the dialysis circuit. So this is a dialysis circuit with lots of air in the dialysis circuit. So where is the problem, and what complication can happen if you continue the patient on dialysis? So as a dialysis nurse, what will you do? What serious complication can happen if you continue dialysis? So air in the bloodline. So air in the bloodline again is a problem. So the most possible causes are, one is connections and caps loose within the extracorporeal circuit. So this is one cause of a air in the dialysis in the blood circuit. Improper priming of the dialyzer and bloodlines. So if you are not paying enough attention and time for priming, this can develop. So clamp to the medication line left open upon accessing. This is one of the most common causes why you get an air in the bloodline. And a cracked catheter, you will have to look at whether the catheter is mechanically good. Then you can have empty air vented IV bottle, like for example, you can give antibiotics or albumin or saline or anything like that. And if it is empty, it can draw air from the empty bottle into the blood lines. And the air detector alarm will go on, and it will alert you to the patient. So how do you manage? So turn the blood pump off, immediately clamp the patient's access and the machine blood lines, and you have to find out the cause. And if the air is noted in the venous sensor, attach empty sterile syringes to access patient access and aspirate the air if it is possible. So all these things should be done to keep the air out of the dialysis blood line. Now the nurse was there was a particular unit where the nurse was extremely negligent, and the patient continued to have dialysis with the air in the bloodline with a faulty air detector alarm also. So all the poor things, all the unfavorable factors combined together, and the patient developed an air embolism. So this is the most dreaded complication if you continue dialysis with the air in the circuit, and if you got a faulty air detector. So this means the air embolism literally means air is found in the patient's blood, and depending upon the patient's position, the air can either go into the brain. If the patient is sitting up in a dialysis chair, the air can go into the brain, and in the brain it can cause affection of the vision, and the patient will complain of defective vision, loss of vision, or the patient can develop neurological problems like headache, nausea, seizures, or even can develop a sudden cardiac arrest and can lose unconscious and can become unconscious. Now, if the patient is lying down supine, the air will collect in the heart, and from the heart it will go into the pulmonary system. It will go into the lungs, and the patient will complain of shortness of breath, uh, chest pain, and the patient can develop a cardiac arrest with the ECG changes. So, how do you treat air embolism? So, if you are picking up this condition and you are thinking that the patient has air embolism, immediately stop dialysis, don't return blood, discard everything, and you have to put the patient in what is known as a durance position. Durance position is something like you keep the patient on the left side and the head should be tilted down. So this is a position that is adapted by the patient. So the aim is to collect the whole air into the right ventricle. So whatever air that is entered into the body will be accumulating in the right ventricle, and you can do some therapeutic maneuver to aspirate the air out of the right ventricle. So this position is known as durance position, and you have to recognize this and do the immediate corrective strategy. So again, the causes are just like air in the bloodline, except that there is a defective faulty air detector on the hemodialysis machine, and you will see visible air or foams in the venous blood, and the patient can have a lot of symptoms as I described earlier. So turn off the blood pump, do not return blood, clamp all lumens of the patient access and all blood lines, discard everything, and put the patient in a durance position. Uh, 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 and you have to aspirate any remaining air with a 10 cc syringe from the dialysis catheter, and check the saturation, start oxygen, and call for help. So this is what you have to do with regards to an air embolism. Now we'll come to another complication which can happen. So this is this patient, Mrs. K, 69 years, chronic kidney disease on maintenance dialysis, was noticed to have blood in the dialysate line. So what are the causes and what is the next course of action? So the blood is taken from the patient's body. It undergoes dialysis in the dialysis membrane. It is returned back into the body. Normally, the dialysate runs from the counter current way, and the spent dialysate is collected goes out in the drain. Now the nurse has noticed that this particular line is turning red. So there's a presence of blood in the dialysate line. So the blood in the dialysate. So one of the causes are hemolysis, as I already mentioned. So because there is a lysis of the RBCs in the blood compartment, the hemoglobin can diffuse hemoglobin and all these things can diffuse into the dialysate compartment, and it can turn the dialysate line red. Then other causes are cracked or faulty headers, fractured dialyzer membranes. All these again can cause blood in the dialysate. And usually it will be detected by the blood leak detector. Usually the dialysis will be terminated by the machine itself. But if I got a faulty sensor, or if you have a problem with any of these things, then you can have blood in the dialysate line. Then how do you manage? So you have to stop the dialysis, clamp blood lines and patient access. You have to inspect the dialyzer outflow dialysate hose for a blood leak. And if there is no definite blood leak, remove the dialysate hose, and you have to test. Ideally, you have to test the dialysate outflow with a test strip, which detects the presence of blood. So if there is presence of blood, then you have to find out what went wrong, where is the problem, call your treating doctor, and fix the problem before you start the patient again on dialysis. So the most important thing is do not return the patient blood. It might be a hemolysis that is happening. So you don't want to put the patient again in jeopardy by returning all the high content of potassium in the hemolyzed blood sample. Now we'll come to the seventh scenario. This is one of the most common scenarios which happens in the dialysis unit. So a 45-year-old male was undergoing dialysis, and 4 hours into the dialysis, near the end of his dialysis, he started to have severe muscle cramps, and the blood pressure was recorded as 110/70. So he came in with a blood pressure of around 160/100. Now his blood pressure is 110/70. His pre-dialysis weight was 68 kilos, and his dry weight was assessed about 1 week back. It was fixed at 63 kilos. And he had a hemodialysis prescription of 4 hours dialysis. Weight loss was targeted around 5 kilos with systemic heparin. So this is one of the most common complications of dialysis which can happen in dialysis unit. I am sure that everyone will be dealing with at least 1 or 2 muscle cramps in a very active dialysis unit. So the causes of muscle cramps, just follow the highlighted areas and those in the circles. So the most common cause is hyponatremia. So this is the most common cause, and this leads to a decrease in the osmolality of the blood. Second most important cause is plasma volume contraction. Then there are other causes like intradialytic hypotension, mineral and electrolyte disturbance. But you remember that the most important cause is hyponatremia and hypoosmolality. So the signs and symptoms that what the patient can experience is involuntary and sustained contracture of the muscle without relaxation. It is really not a pleasant thing to experience, because the muscles will be going into contraction without any relaxation, and it is a severe muscle cramps. So how do you manage this patient? So reduce the ultrafiltration rate to the minimum, decrease the total ultrafiltration target. You have to reassess the dry weight, and you have to fix the ultrafiltration accordingly. You have to massage and stretch the cramped muscle. Start the patient on something to increase osmolality or to correct hyponatremia. Usually the dialysis units or the treating centers will have some policy with regards to this, and usually normal saline is started as a unit protocol. If you want to increase osmolality further, you should start using something which is hyperosmotic, like a 50% H2 solution is hyperosmotic, or you can start a hypertonic saline, which will rapidly increase the osmolality of the blood. This is how you treat muscle cramps. Now, how do you prevent this? You have to regularly and systematically assess ideal weight or the trend in weight, and you'll have to monitor the dry weight and fix the dry weight accordingly. And if you are concerned with excess blood loss, excess ultrafiltration removal, then you have to use dialysis machines with ultrafiltration control with the inline hematocrit monitoring. These are the things which we can do. Then there are other medications which can be used for muscle cramps. Then coming to the eighth scenario, this is a very frightening scenario. This can happen once in a while in a dialysis unit, and this is a medical emergency, and you have to get the help of multiple specialties at the earliest. So a 70-year-old male, Mr. R, was on a regular thrice weekly maintenance hemodialysis through a right brachiocephalic arteriovenous fistula. And 2 hours into his dialysis, he had a torrential bleed from his arteriovenous fistula with a hemodynamic instability. So he developed hypotension and tachycardia. So this is a real nightmare. And how do you manage this patient? So this is a artery. This is arteriovenous fistula. Normally, the artery gets connected into the fistula, and the initial part of the fistula, this is where the vein gets epithelialized, and this is where it can late. And what happens over time, if you puncture at one particular site, is that the patient can develop an aneurysm or a pseudoaneurysm. Pseudoaneurysm, all the three layers of the vessels are not involved, whereas in a true aneurysm, all the vessel layers are involved. And it can, once you develop the aneurysm, the skin over the aneurysm will get stretched out, it will become thin, and and because of the excess pressure as well as repeated cannulation, the vessel wall becomes very friable, and it can lead to what is known as a fistula blowout or a arteriovenous fistula rupture. So acute arteriovenous rupture in a dialysis unit usually happens secondary to aneurysm or a pseudoaneurysm, and the incidence is increased if you have got an overlying arteriovenous fistula infection per se. So infection along with an aneurysm is a really bad thing to happen. So what will you do? Stop the immediate concern is safety of the patient. So you have to save the life of the patient. So you have to stop the bleeding, and the bleeding is life-threatening. You forget about the fistula. You apply a tourniquet or a strong manual pressure proximal to the puncture site, and keep the arm in an elevated position. So this is what you have to do as an emergency basis. You have to stop dialysis and terminate the dialysis, and you have to start measures to stop the bleeding. And if it is a slight loose, and if the bleeding is not life threatening, you can use a two-hand technique. This is a Mayo Clinic recommendation. Use the dominant hand to put pressure on the bleeding point, and the non-dominant hand to put a pressure proximal to the bleeding. So these are the things which have to be done, and call the doctor as soon as possible, and get immediate help. So this patient cannot be kept in a dialysis unit. This has to be shifted into an intensive care unit. You need to have access to vascular surgeons and mm, other surgical options as well. So this is, I have gone through one of the uh, most common complications that you encounter during dialysis. And because of the paucity of time, I have taken only the most important causes that you can commonly encounter in a dialysis unit. Of course, there are a lot of other complications which can be discussed, but this being the most common complication, I thought this will be the worth these will be the complications that will be worth discussing. So I put it in a case-based questionnaire and the possible solutions to this. Now I'll wind up with the question of the day. This is a quiz, and all the following can predispose to the development of intradialytic hypertension except. So the question is except taking a heavy meal during dialysis, taking antihypertensive medication before dialysis, low dialysate fluid temperature, low blood flow rate. So thank you.